Hello.
Yes, sir.
Yeah, start off.
Yes, sir. I'm going to present a case of a 70-year-old male, a laborer by occupation, came with chief complaints of loss of appetite since 6 months and complaints of vomiting since 2 months. Patient was apparently all right 6 months ago. Then he developed a loss of appetite, which was insidious in onset and gradually progressive. And patient also gave history of vomiting since past 2 months, which was projectile in nature, non-bilious and non-blood stained, consists of undigested food particles after 1 to 2 hours of food intake, which was more with solid food but not with the liquids. History of generalized weakness present and history of loss of weight present, but the quantity was uh, uh, not mentioned by the patient. The patient is not aware of the quantity of the loss of weight. There was no history of abdominal pain and no history of melena, and there was no history of altered bowel and bladder habits, and no history suggestive of distant metastasis. Past history: patient had abdominal surgery for peptic ulcer disease 6 years ago, and patient doesn't have any medical comorbidities. And family history: there was no history of similar complaints in the family and any history of malignancy in the family members. Allergic history: patient doesn't have any allergies to medicines. Personal history: patient consumes mixed diet, appetite was decreased, and sleep was adequate. Bowel and bladder habits were normal. Patient consumes alcohol since 20 years and not taking since 2 months, and he had a habit of smoking since 20 years. That is 1 pack per day. He is used to smoke BD. Summarizing the history: a 70-year-old male came with complaints of loss of appetite since 6 months and vomiting with undigested food particles within 1 to 2 hours of food intake, which was since past 2 months, with history of generalized weakness and loss of weight.
Okay, Indraja, go back to first slide.
Yes, sir.
Yeah, Nikita, do you think history is adequate? Next slide, next slide.
Yes.
Or anything to be added or modified?
Uh, it looks uh, it looks adequate, sir.
You don't want to add anything or modify anything. What
No,
do you what do you mean by loss of appetite, which is insidious on onset and gradually progressive? What do you
Sir,
mean by progressive loss of appetite?
patient had loss of appetite, sir. Like he doesn't know how it
Sir,
started.
I think Gurushantappa sir has logged in.
Yes,
Sir,
sir.
good evening.
Yeah, good evening, good evening, good evening.
Yeah, sir, we have just started off.
Yeah.
So she's presenting a case of mass per abdomen.
Okay, yeah, just.
Yeah.
Thank
Nikita, you were telling me something. What do you mean by progressive loss of appetite? Is there something like that progressive loss of appetite?
Sir, actually, loss of appetite gradually increase. Like before, like it was started. He doesn't know how it started, but it was progressively increase.
Gurushantappa sir, do you agree, sir? Progressive loss of appetite?
Yeah, just a second. Just I'm connecting this audio. There is some
Sure, sure.
problem. 1 second.
Sure, sir. Sure, sir. Sure. Indraja,
Yes, sir.
till Gurushantappa sir logs in. Okay,
Yes,
we'll
sir.
talk about progressive loss of appetite once sir's, after sir's opinion.
Yes,
History
sir.
of loss of weight, you said. You
Yes,
want to
sir.
like you want to like Explain it in a better way.
Sir,
History
I
of
didn't.
loss of weight. How much?
Yes, sir.
In
So
how
that's
many
what
months?
I actually since the loss of weight was there since past 4 months he's observing, but the quantity of loss of weight he's not sure, sir.
Approximately.
Like I didn't measure weight before
Is it
and after.
significant or not
Sir,
significant?
approximately around
How do you like
significant, sir,
if
around
he's
4
not
kg.
able to quantify the weight loss, how will you ask for
Yes,
that,
sir.
whether it is significant
Sir,
or not?
whether his clothes becoming loose or like.
Correct.
Yes, sir.
So is it there or not there?
Sir, it is there, sir.
Okay. So did you ask a leading question? How many kgs he must have lost, or did you have any idea how much weight he was?
That's what I asked, sir, but he was not aware of that how much weight he was before and now.
Okay.
Yes.
So what do you consider as significant weight loss, Praveen?
Sir, loss of 10 or more kgs in 6 months of duration, sir.
10 or more kgs.
So, more than 10 kgs.
More than 10. Where, according to which definition? Where? Is it 10 kgs or percentage? You know, Vinod?
Hello, sir.
What is significant weight loss?
More than 15%, sir. 10 to 15% in 6 months.
10 to 15%.
Yes.
Pravan, is it right?
Yes, sir. Sir, more than 10% in past 6 months, sir.
Sania?
6 to 12 months, I think.
So 10% of his body weight in the past 6 months.
Yeah, correct. Okay. What is your opinion regarding progressive loss of appetite?
Sir, I don't think so there's anything called as progressive loss of weight. Loss of appetite. It is either there is presence of
It's loss of
or no
appetite
loss of
only.
appetite.
You can either loss of appetite is there or not there. It
There's
can be
nothing like
like
progressive
you can't quantify that loss of appetite. Better not to avoid those controversial terms. Better
Okay,
to
sir.
avoid them. Okay.
Okay,
So
sir.
don't
Okay,
use them.
sir.
You say insidious onset, patient has
Okay.
loss of appetite
Okay,
since
sir.
last 6 months.
Yes, sir.
Okay, with loss of weight.
Yes, sir. Okay, sir.
Next, go to next slide. Why did you ask for distant metastasis? What was your diagnosis?
Sir, since a patient is having like vomiting with undigested particles, sir, since 2 months, sir, I'm suspecting any malignancy, sir, and loss of appetite
Okay.
and loss of weight
Okay.
also is there. So that's why I asked for the any history of jaundice, any breathlessness, any bony pain. I have asked him, sir. So he said he's not having any.
Why did you ask for distant metastasis? What is your diagnosis? Which diagnosis are you considering?
Sir, I'm thinking of malignancy of the stomach, sir.
Your voice is breaking.
Hello, sir. Can you hear me?
Hello?
Hello, sir. Can you hear me, sir?
Yeah, now we can hear. Yeah, now we can hear.
Yes, sir. Sir, I am thinking of malignancy of the stomach, sir. Hello, sir.
Hello?
Yes, sir. I can hear you, sir.
Hello? Yeah,
Hello,
your
sir.
voice is breaking on and off. You are not able to hear. Hello?
Sir. Hello, sir. Can you hear me?
Is everyone able to hear her?
Yes, sir. We are able to
Yes,
hear.
sir. We are
Yeah,
able
now we
to
can
hear,
hear.
sir.
Hello, sir. Hello.
Now I can hear you. There is, I think, some internet issue. Hello?
Yes, sir.
Can
I
you
can.
hear me? Hello?
Yes, sir. Yes, sir.
Yeah, you are telling something. Yeah, tell.
Sir, with history, I'm thinking of malignancy in the stomach, sir. Sir, can you hear me? Yes,
Okay.
sir. So that's why I asked
Yeah,
for
yeah, I
the
can.
history of any breathlessness or any bony pain he's having, or any recent history of any jaundice. I asked him, sir.
Okay. What is your other differential diagnosis? Because you have given one more significant history later in the next slide.
Yes, sir. It
Hmm.
can be due to like a peptic ulcer, sir, like peptic ulcer, stricture due to peptic ulcer disease.
What was the surgery done? That also you're not like highlighted completely.
Sir, actually, they're not aware of that, sir, what surgery was done.
What were his presenting symptoms at that time?
See, sir, he had a severe pain. Like he used to
Okay.
have pain. Sir, actually, he's an alcoholic and smoker, sir. So
Hmm.
he used to have severe pain. So that's why he's consulted regularly. The pain is not subsiding, sir.
No, 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 no. I'm very
Yes, sir.
specifically asking you. You
Yes,
have
sir.
said abdominal surgery for peptic ulcer 6 years ago.
Yes, sir.
Okay. So how does
Yes,
he know
sir.
if he's not aware that he had peptic ulcer?
So he said surgery for some ulcer he underwent.
Okay. So what was the
Yes, sir.
presenting symptom at that time? So based
So
on that, you can take a guess whether he had similar gastric outlet obstruction findings history, or whether he had acute abdomen history.
yes, sir.
See, if he had acute pain abdomen and they operated on an emergency basis, it invariably will be a perforation.
Yes, sir. Yes, sir.
So if it was like a chronic similar symptoms, then it probably they would have done GJ. Now the diagnosis can be a blockage of the GJ.
Yes, sir.
So that will give a history, no? That your history has to be thorough.
Yes, sir. Yes, sir.
So that is one. Sir,
Yes,
Gurshantapa
sir.
sir.
Yeah, Niranjan, I do agree. We have to have straightway. How did she decide that yes, it was surgery for peptic ulcer? Was there any documentation you could see with the patient?
No, that is what
No,
she is telling. He just told that he has undergone surgery for ulcer.
Okay, Indraja,
yes, sir.
Niranjan is asking, no, to know whether it is an elective surgery or as an emergency surgery. How does it make for the present diagnosis? To know this difference on history wise, how do you know was it an emergency or elective surgery?
Sir, if we had acute pain at that time, like acute severe abdominal pain, it might be a
Okay,
perforation.
operated immediately and
Immediately.
after evaluation then operated.
Yes.
How does it matter for your case now in the diagnosis? How does it matter? If he has undergone surgery for peptic
Yes, sir.
ulcer disease as an elective procedure,
Yes, sir.
does it matter? If so, how? For the present diagnosis at history level.
Sir, patients who underwent surgery for peptic ulcer, sir, there is increased risk of malignancy, sir.
Okay, what surgeries for peptic ulcer disease on stomach are prone to develop malignancy of the stomach?
Sir, drainage, vagotomy with drainage procedure, sir, because there is a stasis of the bile or biliary reflex, sir.
Okay. What type of drainage procedures are more prone to develop malignancy or reflux biliary gastritis and then malignancy?
It's a gastrojejunoscopy.
Okay, in other way around, what
Yes, sir.
type of drainage procedures are less likely to have this complication, late complication? Less likely. What type of drainage procedures?
Sir, I'm not sure, sir.
See, ultimately it's a biliary gastritis, which is the pre-malignant condition of the stomach. Is it not?
Yes, sir. Yes, sir.
So
Yes,
you
sir.
should select as such a procedure, drainage procedure, where bile will not come into the stomach, but it will go down into the small bowel. So what?
Gastrojejunostomy with jejunojejunostomy, sir.
Okay, that is one. What is that called?
Sir, Ruenway.
This is not Roux-en-Y. If you
Yes,
say gastrojejunostomy and jejunojejunostomy, it is a limb
Sir.
anastomosis.
Yes,
You
sir.
have two limbs, afferent
sir.
and efferent. So you are doing
Yes.
anastomosis between those two limbs. So that is called
Yes,
limb
sir.
anastomosis.
Yes, sir.
Okay, afferent and efferent. So that is one. And second, what I expected was Roux-en-Y gastrojejunostomy.
Yes,
So
sir.
if you plan Roux-en-Y, then that is less likely to have a biliary gastritis and then predisposing to malignancy.
Yes, sir.
Is it not? So
Yes, sir.
history-wise, just because he has mentioned he has undergone surgery, yeah, keep a possibility. But if he has undergone Roux-en-Y, then he's a less likely candidate
Okay,
for
sir.
developing.
Yes, sir. Yes, sir.
Oh, okay. And before that, you people were talking about progressive. What is that? What is that?
Loss of
Loss
appetite.
of appetite, sir.
Yeah, I don't know. Better don't to use those adjectives for that type of symptomatology.
Okay, sir.
Whether it
Okay.
is there or not, that's what matters.
Okay, sir.
If you're talking about dysphagia, I can understand. Yeah, today it was less, tomorrow it is more, day after tomorrow it is more. Then we label that as progressive.
Okay,
For
sir.
appetite, whether it is there or not there, that's all.
Okay, sir.
Okay, fine. Yeah,
Okay,
continue. Continue.
Sir, anything else in the history, sir? You will expect?
Every time she
Or-
was telling that, I'm thinking in terms of CS stomach at history level, which is probably wrong. So
Yes.
you should,
So you can broadly classify just to better to say gastric outlet obstruction will be a better term, sir.
yeah, term or something, some pathology concerned with stomach. What is
Okay,
that?
sir.
We'll come to know later.
Okay, sir.
Which in okay.
Hello, sir.
So
Yes. Sir, your voice is breaking, sir.
fine.
Hello, sir.
I think sir's network some issue might be there.
Yes, sir.
Continue.
Yeah, continue.
Yes.
Continue.
Yes. Yes, sir. Yes. On examination, patient was examined in supine position with arms by the side after taking verbal consent in a well-lit room with adequate privacy. Patient was conscious and oriented with Kornowski performance score of 80 and ECOG score of 1 and moderately built and nourished. On pallor was present. There was no icterus, cyanosis, clubbing, pedal edema, and generalized lymphadenopathy.
Indraja,
Yes,
wait.
sir.
Why do you
Yes,
say
sir.
Karnofsky performance score of 80?
Sir, because
do you-
he's able to carry out his work, sir, but with the difficulty when compared to the before.
Okay, like example?
Like before, he used to walk for some distance and he used to lift weights and all, sir. And but whatever he's doing the work before, he's not able to do properly, sir, in past 6 months, sir.
Okay.
Yes, sir.
Okay, continue.
Patient vitals, temperature 98.6 degrees Fahrenheit and pulse was 92 per minute measured in right radial artery with regular and normal volume. Blood pressure 140 by 90 mm of Hg measured in right brachial artery in supine position and respiratory rate was 20 cycles per minute. On abdominal examination, on inspection, abdomen is scaphoid in shape, normal with normal inverted umbilicus, and there was midline laparotomy scar present, and we noted upper abdominal fullness present. All quadrants are equally moving with the respiration. There was no visible gastric peristalsis. Hernial orifices appears intact and external genitalia appears normal. On palpation, there was no local rise of temperature and no scar tenderness. There was vague mass palpable in the epigastric region with ill-defined borders, and there was no hepatosplenomegaly, and bilateral hernial orifices intact, external genitalia and meatus normal, and bilateral testes palpable, which were normal. On percussion, dull note over the swelling was present and there was no evidence of free fluid in the abdomen. On auscultation, bowel sounds were present and there was no evidence of succussion flash. On systemic examination, respiratory system, there was no evidence of pleural effusion. And on cardiovascular system, there was no abnormality detected. And on neurological examination, there was no focal neurological deficit. Examination of bilateral supraclavicular region, there were no palpable lymph nodes. And rectal examination was done, no abnormality detected. Summarizing the history, a 70-year-old male came with complaint of loss of appetite since 6 months, vomiting with undigested food particles within 1 to 2 hours of food intake since 2 months, with history of generalized weakness and loss of weight. On general examination, pallor present. On inspection, upper abdominal fullness present. On palpation, there was vague mass palpable in the epigastric region with ill-defined borders with dullness over the mass.
Okay.
Yes, sir.
Go to inspection.
Yes, sir. Yes, sir.
You said abdomen is scaphoid, but you again told upper abdominal fullness is there. What is definition of scaphoid?
Sir,
Can you call this as
scaphoid,
scaphoid? When
sir,
there is upper abdominal fullness. It should be in like concave, no? If that is what
yes,
is
sir.
called this thing. Here it cannot be
Sir,
concave because you are saying upper abdominal there is
the
fullness.
Yes, sir.
Sir?
Yeah, you are right. You cannot put this as a scaphoid abdomen.
Okay, sir.
Because even on inspection, we can see costal margin is not seen. In fact,
Yes, sir.
in the subcostal area on either side, it is
Yes,
full.
sir.
It is full. So don't put this as a scaphoid. In fact,
Okay,
you
sir.
can put it as there is a fullness in the upper half of the abdomen on either side, in the subcostal
Okay, sir.
area.
Okay, sir.
Okay. And VGP was absent in this patient.
Yes, sir. It was not there, sir.
You checked.
Why do you think it was not there?
Yes, sir. There was placed a Ryle's tube, sir. They're draining the gastric contents, sir.
Then you should highlight that point.
Patient had a
Patient-
Ryle's
Yes,
tube.
sir.
You should mention when you're
Yeah.
mentioning general physical examination.
Exactly.
Yes, sir.
You should have mentioned that. And what is the color of the RT aspirate?
What was the content? Indraja?
Hello, sir.
What was the content? Sir is asking color.
Yes, sir.
RT
What was the
aspirate.
RT aspirate? Color and content.
Sir, brown color, sir.
So it was bilious.
Was it bilious or non-bilious?
Sir, not bilious, sir. It's like thick brown colors.
It should be bilious, no? If it is brown in the sense coffee ground.
Or was it
Yes,
containing
sir.
food particles with what? Coffee ground barometers.
Sir, yes, sir. Coffee brown only, not bilious, sir.
Okay, then that must be what does it indicate?
Hello, sir.
Then what will it indicate if it is coffee brown?
Indraja, there is some problem with your internet. Probably you are not able to hear us.
Indraja?
Sir, now can I hear?
She's
Yeah,
not
yeah.
able
Hear
to
me,
hear
sir?
us.
Yeah, we can hear. Tell. What does coffee brown this thing indicate then? Hello?
Sir, the contents are mixed with acid, sir. Hello, sir.
Yes, continue.
Hello.
Yes, we can hear.
Sir, 1 second, sir. I'll just log out and log in.
Now you are clear.
Okay.
Now you're clear.
Yes, sir. Yes, sir. Okay, sir.
Tell us, what does coffee brown indicate then?
Mm.
Nikita?
Sir, the gastric contents,
Yeah, tell. Gastric contents?
the gastric contents are mixed with acids, like
Gastric content is only acid. Gastric, and you mean by food mixed with acid?
yes, sir. Yes, sir.
It will not be coffee brown. No, you will see food particles there. Coffee brown means Nikita is answering it. There must be a bleeding inside the stomach. Sir?
Yeah, that's what she should substantiate. She said general physical examination patient has got pallor.
Pallor, yes.
And now you are telling that arteriospirate is coffee ground. So obviously, what should be your inference? Patient has
Yes.
pleudal edema also, if I remember correctly.
Bleed.
So what is that?
Sir, no,
And you
no.
said the patient also is Karnofsky is not 100, it is 80. So everything fits into what? There is something going on there because
Yes.
No, are we audible to you or not? Because we are not hearing your
Sir,
answers.
your
Like,
voice is
being
breaking.
interrupted.
Now it is clear, sir.
Is it
Sir, voice is
Probably
breaking. Sir,
some network issue. Your voice is breaking on and off, sir. Hello. I think sir has
Yes,
just
I
logged
can hear.
out.
Sir.
Yeah. So the thing as sir was mentioning,
Yes, sir.
so you have to mention it clearly, the trials tube, what was that and all that. So then there you can explain that there was no visible gastric peristalsis. Okay, on this thing. So because
Okay, sir.
patient has
Yes,
already,
sir.
if you mention
Yes, sir.
that patient already has a Riles tube in, so then you will not get the
Yes, sir.
questions that why there is no visible gastric peristalsis there.
With gastric peristalsis. Okay, sir.
Okay. So anything else missing
Yes,
in
sir.
this thing inspection? Anyone else? Sanya, you want to ask her something?
No, sir, I think inspection is complete.
She has mentioned everything.
Yes, sir, almost you mentioned everything.
Nikita?
Yes, sir.
Okay. Anyone else has any questions on inspection? No. Okay, next slide. Go to the next slide.
Yes, sir. Yes, sir.
Okay, palpation. Is that palpatory findings enough? Nikita?
No, sir.
What is not enough then?
Regarding the mass, though it is ill-defined, we just need to know the approximate size which we are able to palpate, sir.
Correct.
And
Then
also if possible, any mobility of the mass and the consistency.
correct. Good. Then
Surface
correct.
mass.
Correct. Then
And that's it, I guess, sir.
anything else? Just think. From where is it coming?
Stomach, sir.
How do you know it is stomach?
Does the size increase after intake of food or?
Okay, good. That is in the history.
Yes, sir. In here.
Huh?
Yes, sir. So in
No, here like site of origin, at least approximate site of origin.
yes, sir.
Whether it is intraperitoneal or retroperitoneal, how will you check?
It is, sir.
Moving.
Huh?
Palatability or
Palatability in midline epigastric swelling. What midline epigastric swelling will be palatable?
No, sir. Only kidney is retroperitoneal.
No,
But
I'm
in this
asking for any intra-abdominal swelling. How will you differentiate intraperitoneal or retroperitoneal? What test you will do?
we'll increase the intra-abdominal pressure and see the
That is to differentiate whether it is from the anti-abdominal wall, or whether it is from the intraperitoneal, whether it is from the peritoneum. Pawan?
Sir, leg raise test and head raise test.
No, that same thing I told. It is from anti-abdominal wall or intraperitoneal. Final years.
Knee chest position, sir. That means
Knee elbow position nobody does. What is other simple test?
movement along the mesentery, sir, or the attachments.
No.
No.
Falling forward, no. You ask the patient to lie down on the side and bend, and turn. So if the mass falls forward, what is it?
Lateral decubit.
Yes, lateral decubitus, and ask him to
Sir,
turn.
if mass falls down, it is from the intra-abdominal, sir.
Peritoneum.
Intraperitoneal. And if it doesn't?
Intraperitoneal, yes, sir.
Hey.
It is it is retroperitoneal origin.
Tanya, you agree?
Yes, sir. If it falls down forward, then it is intraperitoneal. If it doesn't, then it's retroperitoneal.
Yes, and what else? What other test she has missed? Whether the mass moves with?
Respiration, sir.
Yes.
Respiration.
Yes, you are not mentioned.
Yeah, with respiration.
So all those things are important or not? You want to rephrase that palpatory findings now?
Yes, sir, important, sir.
Yeah. So you want to tell all those things now?
Sir, there was a vague mass, sir, palpable in the epigastric. Yes, sir. There was vague mass palpable in the epigastric region, sir, with smooth surface, with a firm consistency, sir.
Okay.
Which moves with the respiration. Moving with the respiration. Yes, sir.
Continue. Hello?
Yes, sir. So actually the borders I couldn't feel, sir. That's why I didn't mention the size, sir.
No, approximately whatever you can feel, approximately it is that whatever I can feel, because you mentioned ill-defined borders, nobody will ask you the exact size. Whatever you could mention, you can approximately it measures this much to the extent which we can palpate. Rest of the
yes,
mass
around
hello?
Yes, sir. Yes, sir. Hello, sir. Sir, a vague mass palpable in the epigastric region of approximately size around 6 cross 7 centimeters with a smooth surface and firm consistency, which is moving with the respiration, sir.
Okay.
And there was no hepatosplenomegaly. Bilateral hernial orifices were intact, sir. External genitalia and meatus normal, and bilateral testicles palpable, sir.
Okay.
Yes, sir.
You have to mention about spine and all those things you mentioned later.
No, sir. Spine I didn't mention, sir.
Spine also.
Spine I didn't mention, sir. Spine I didn't.
Okay.
Yes.
Anything else, Anya? Missing?
No, sir. He's covered everything.
Okay. What's your? You want to give us a differential diagnosis or diagnosis?
Sir, diagnosis I will give, sir. I will tell the other.
How do you mention if it is like if they have not put the Ryle's tube? Okay.
Yes, sir.
So what is the characteristic of VGP, visible gastric peristalsis? Tell us.
Sir, visible gastric peristalsis, it starts from left to right, sir. Left hypochondriac umbilical and right hypochondriac region, sir. We have to sit by the side of the patient, and we have to observe for the peristaltic movements, sir. It will be from left to right.
Okay.
Yes, sir.
Then what other test you would have done?
Sir, succussion flash, sir.
Splash. How do you do that?
We have to place the bill of the stethoscope in the epigastric region, and we have to shake the abdomen, sir. We can
When?
hear, sir.
When you have to do something before that?
We had give the water to the patient, sir.
How much?
So actually,
All
this
this
test were
bleeding.
like one after intake of liquids or solid with after 2 hours, sir.
Huh?
Succussion flash after taking food or liquids after 3 hours, sir.
Okay.
So we have to place the bill of the stethoscope in the epigastric region, and we have to shake the abdomen, so we can hear the sounds. We can hear this splash sounds.
When? In case of what you will hear?
Gastric outlet obstruction,
Why will you hear?
because of the accumulation of the fluid in the stomach, sir. Because of the distended stomach.
Because of the distant stomach.
Distended
Suppose.
stomach.
So how will you artificially induce this?
We have to give the water, sir, either through the Ryle's tube or mouth.
How much?
Orally, around 1 liter of the water, sir.
Around 750 ml approximately. Okay.
Okay.
Then?
Then we have to place the stethoscope and shake the abdomen, sir.
Okay. Fine. That is one thing. There is also one more diagnostic aspiration. You push in 750 ml of saline, and
Yes, sir.
then after half an hour, if you were able to aspirate around approximately more than 400 ml, then it
Okay.
means that large quantity of it is still getting retained in the stomach. Okay.
Oh, yes, sir.
So that is also an indicator of gastric outlet obstruction.
Okay, sir.
Okay.
Yes.
Okay. So yeah. So any other tests, Sania?
Oh, so that only those I think, sir. I cannot recall any other test.
Huh?
I cannot recall any other test. So whatever she's done.
Yeah. Okay. Okay. Fine. Okay. Indraja, come to
Yes, sir.
your diagnosis or differential diagnosis.
Sir, I will go with the differential diagnosis, sir.
Okay.
Yes, sir. So first diagnosis is gastric outlet obstruction, sir. Secondary to the malignancy of the stomach, sir, carcinoma stomach.
Okay.
And it can be due to because of the peptic ulcer disease also, sir, which is causing the obstruction.
Okay.
And other ones like it it may be due to the extraluminal obstruction also, sir, but not in this case.
Why do you say it like that?
Sir, extraluminal obstruction means maybe because of the periampullary carcinoma, which is causing gastric outlet obstruction, sir. But in this case, most of the periampullary carcinomas will have presented with jaundice, but this case is not. So.
No. Not all. It need not be. If it is in the head and uncinate process,
Yes, sir.
it need not be. They can
Yes,
present
sir.
later also.
Okay.
So instead of
Yes.
getting into specifics, it's probably due to malignancy. Okay, extraluminal, how do you
Malignancy.
completely
Yes, sir.
rule out in this case?
Sir, this is non-bilious vomiting, sir.
Okay.
It is only after immediately after taking food.
It is 1 to 2 hours.
Yes, like
Extraluminal
1 to
obstruction
2 hours,
also
sir.
can present the same way, right?
Yes, sir.
So how do you differentiate? Anyone else?
Sir, as the patient also has
Some patients with pain.
Huh? Who is answering? Nikita or Indraja?
sir, as the patient also has
Nikki.
coffee ground vomitings or coffee ground trials aspirate, it means there is some intraluminal pathologies involved, sir.
Most likely, because one already patient has had peptic ulcer, okay, and now patient also has a like a vague mass which is almost occupying the entire area, and it's a single mass.
Yes,
So
sir.
if it is extraluminal compression, then the stomach also has to be dilated, and also you can feel the stomach, as well as there probably will be another mass which you will be feeling, which probably will not be smooth.
Yes, sir.
Okay, and as Nikita
Okay.
said, there is bleeding intraluminal.
Yes, sir.
Most likely it is due to intraluminal. Can extraluminal
Yes, sir.
compression cause bleeding?
Intraluminal, sir.
Extraluminal causes.
Hello, sir. Yes, sir.
Nikita was
Sir, I
telling,
didn't
no,
get your question, sir.
can extraluminal causes also produce bleeding? Intraluminal bleeding. Nikita,
There is a chance, sir, if the mechanical obstruction is very high and if the lumen is pressing to each other, there could
there can be mucosal ulcerations and can produce bleeding. Okay, but however, it is
Yes, sir.
usually commonly seen in intraluminal pathologies. Okay, so
Yes, sir.
gastric outlet obstruction is the diagnosis with differential diagnosis of either due to malignancy or due to peptic ulcer
Benign
disease.
peptic
So what
ulcer.
do you
Yes,
think
sir.
is most common?
Sir,
This
malignancy, sir.
Why?
Because of the age of the patient, and is also having the loss of weight and loss of appetite, sir.
Okay. What if the
And
peptic
he's
ulcer
also
disease which
having
he
the
had
generalized.
previously would have progressively worsened?
Yes, sir.
Is that possibility there, or is it less likely? And if it is less likely, why?
Sir, less like.
Okay, why? Anyone else?
Mass in the epigastrium.
Yes.
What mass in the epigastrium?
Some way, epigastric mass, madam is saying.
Huh?
Complaining of epigastric mass, sir, which is not possible in gastric peptic ulcers.
Why? If there is
Sir,
complete obstruction, those patients also will present with visible gastric peristalsis and dilated stomach.
sir, but it won't be in margins won't be irregular, sir. Mass
She has not said surface is irregular.
indefinite.
She has said margins she cannot completely, margins are not clear because it is merging.
And consistency is formed, sir. If it is distance and it would be in percussion. It will be in the gaseous distance.
No, if the consistency is hard, then you can say malignancy. No,
Yes, sir.
even in benign this thing, it can be firm.
Sir,
She has not felt any hard mass there.
sir, but if it is a peptic ulcer disease, chances of firm consistency are there.
Huh?
If it is a peptic ulcer disease which causing gastric outlet obstruction, the mass won't be firm. I feel, sir. It will be like a gaseous distance and most probably are because of fluid.
Why? What do you
Stomach.
mean by gaseous system? What will be the consistency then? You mean soft it will be?
Yes, sir, I feel.
Gastric outlet obstruction can also be benign ulcers forming a mass due to chronic fibrosis. Okay, so
Yes, sir.
they also
Yes,
can
sir.
be formed. That is not the answer, because
Sir,
patient already has had peptic ulcer disease and probably has
Yes, sir.
undergone surgery, definitive surgery for that, either in the
Yes,
form
sir.
of either repair of DU perforation or GJ and vagotomy, we don't know. So there will
Yes,
be
sir.
less likely chance, even if he has undergone just a ulcer perforation closure, more invariably those patients would have been put on long-term PPIs. So the
Yes, sir.
disease progression possibility will be very, very less.
Okay, sir.
Okay, so it is more likely to be
Yes, sir.
malignant cause rather than a peptic ulcer causing
benign
gastric outlet
peptic
obstruction.
ulcer.
Benign.
Yes.
Okay, so in this case,
Yes,
and
sir.
what are the other
Yes, sir.
contributory
Okay.
factors?
Base of
Is
Sir,
it
age
is a
is a alcoholic and smoker, sir.
smoker? Smoking is more risk
Risk.
compared to alcohol. Smoking has more risk. Okay,
Risk. Yes.
so all the risk factors are there. So okay,
Yes.
we'll agree. Any Sanya, you have any other differentials, or you want to ask any other thing?
No, sir. We can go with the this diagnosis only.
Okay, so gastric outlet obstruction, probably malignant. Okay,
Yes, sir.
so how will
Yes,
you?
sir.
What will you do next?
Sir, first I will do the investigations to confirm the diagnosis, sir. Sir, first I will go with the upper GI endoscopy, sir. After emptying the contents of the stomach, after placing the Rayleigh tube, I will do the upper GI endoscopy, sir. Hello, sir. Hello.
When will you do? When will you do? So you put just trials. You just put trials tube and then do endoscopy.
No, sir. After giving the stomach wash,
How long you will give? How many times you will give?
sir, we until the clear fluid comes, until
So
the
invariably, if it is a chronic thing, how much time will it take?
sir, 1 or 2 days, sir.
Yeah, maybe at
1
least
or
24 hours
24
for
hours.
it to
Yes.
clear out. Okay.
Yes.
So
Yes,
how
sir.
often will you give?
Sir, every 2 hours, sir.
Anyone else? Sanya?
So there's a little disruption. I didn't hear what the question was, sir.
No. Ask us.
She was answering on what this thing I could not get it.
Stomach
So little
wash, at
disruption.
what frequency we will give, sir, is asking, ma'am.
Stomach wash is twice morning and evening once, just to clear the contents and get the tonicity of to reduce the edema or whatever is there, and to get back the tonicity of the stomach. Twice a day would be sufficient. You said
There is
every 2
no.
hours, no?
Yeah,
Yes,
yeah,
ma'am.
she
Yes,
said
ma'am.
every 2
Every
hours.
2
There
hours
is
would
no.
be too much to give.
Yes. Okay. Okay.
It's not like too much. There is no strict criteria. Okay, if the
Yes, sir.
contents are too much, giving only twice a day is not enough. So
Okay.
it's like most of the places they have given it as 1 to 2 hours if you're planning any surgery or any intervention. So if you
Yes,
want to
sir.
do endoscopy, you want the stomach to be clear.
Yes,
Based on
sir.
how thick it is and how bad the contents are, you can give it in 1 to 2 hours. If it
Okay.
is very less, this thing you can give it in like thrice a day or 4 times a day or even twice a day.
Okay,
Okay.
sir.
So in
Yes,
this
sir.
case, it's a chronic one. Probably you need to give it for first 24 hours till the contents clear out.
Yes,
So
sir.
probably 1 to 2 hours.
Yes,
Okay.
sir.
So before doing that, so you will have time. So simultaneously, you said patient is having pallor. So
Yes, sir. Blood.
you need not have to tell that I will only do endoscopy first and then only we will do a rest later.
Yes,
So
sir.
you can
Yes, sir.
do. So I would like to do all these tests. One is blood investigations.
Yes, sir.
Second one is a radiological investigation, and third one is an endoscopy. I'll
Yes,
put in
sir.
a rail tube, give a wash, and in the meantime, there will be time for you to do all this radiological investigation and blood tests. What
Yes, sir.
all tests you will do?
Sir, ultrasound abdomen and pelvis, sir, radiological
So
investigations.
minimum is ultrasound abdomen pelvis.
Ultrasound.
Yeah. So what will
Followed
ultrasound
by,
abdomen pelvis tell?
sir, first we'll look the uh, growth, where is the growth, exact location of the growth, and size and thickness, whether it is circumferential growth or how much length is involved and how much thickness is involved.
Will you be able to tell all those things on ultrasound?
Sir, length and thickness we can tell, sir, in the ultrasound.
Not very accurately.
Exactly.
You can probably, main thing what you will come to know in ultrasound is site of origin, whether it is from stomach or whether it is from something else.
Yes,
Okay.
sir.
And
Yes, sir.
approximately where the location of the
Location.
obstruction is. Okay.
Yes, sir.
And
Yes,
you
sir.
can say wall is thickened or not, whether there is a mass seen or not. In very good, like sonologists can tell all those things.
Okay,
But
sir.
most often you won't be able to measure the length
Measure.
and all those things accurately.
Okay, sir.
So basic minimum investigation you can tell
Yes,
is
sir.
I will do ultrasound and
Ultrasound.
endoscopy, or
Okay.
you can straight away tell, since you're suspecting gastric outlet obstruction, I will straight away go ahead with endoscopy as well as
See, contrast enhanced CT, sir.
CT,
Abdomen and
abdomen and
pelvis.
pelvis. Yes.
Pelvis.
And
Yes,
if there is a malignancy suspected, along with that,
PET CT, sir.
no,
Or
no, no.
CT chest. CT
Yeah,
chest.
CT chest too.
Yes. To rule out the lung metastasis, sir.
Yes. Okay.
Yes, sir.
So PET CT is an optional, not compulsory.
Okay,
Okay.
sir. Yes, sir.
Yeah. So in this case, what you will do? So all these
Yes.
things were done.
Yes, sir. Can I show, sir?
Yes.
Sir, initially ultrasound abdomen was done, sir.
Hmm.
Which showed a circumferential hypoechoic wall thickening in the distal body and pylorus of the stomach, sir, for a length of 7.8 centimeters with thickness 2.5 centimeters, sir, causing a severe luminal narrowing with dilatation of the stomach and mild internal vascularity with surrounding fat stranding and lymph node. They gave us a query neoplastic etiology.
Okay.
Followed by that, blood investigations were done, sir, which showed like HB 7.4 grams percentage, and they were also done CA and CA99, sir. CA99 was slightly high, 100.3, sir.
Hmm.
And followed by that, upper GI endoscopy was done, sir, in month of the April.
Hmm.
So there is a ulcerated growth of about 4 cross 2 centimeters seen in the deformed antrum and involving the pylorus, sir. At that time, scope can be passed across the lumen, and they took the biopsies, sir. And again, endoscopy was done in the month of May, which showed ulceroproliferative growth at antropyloric region, where multiple biopsies were taken, sir. In this time, the scope can't be passed beyond the gastric outlet, sir.
So that is how much time was there
Right.
between the first and second?
Sir, 1 month, sir, 1 month duration, like 20 days, sir, not 1 month.
Okay.
Yes, sir. And
Pawan?
histopathology showed poorly differentiated.
Okay. Pawan.
Yes, sir.
Will CA99 be elevated in CS stomach?
Sir, actually not so, sir. But it's not a definite, sir.
What do you mean by? What is your answer? I didn't get your answer only.
Sir, CA99 is usually most likely elevated in pancreatic
No,
neoplasm,
I'm
sir.
asking specific question. Will it can it be elevated in CS stomach?
No, sir.
Vinod?
It can be elevated, sir.
Nikita?
It can be elevated, sir.
In what percentage? So it can be elevated in 15 to 30% of gastric cancers. Okay, Pawan.
Yes, sir.
So it is not only for CA pancreas. Okay. In 15
Okay.
to 30% of gastric cancers also CA99 can be elevated, although it is of no prognostic value.
Okay, sir.
Okay, even negative or positive doesn't mean anything. Okay.
Okay.
So if it is elevated, probably for follow-up, you can just see how the CA99 levels fall, or what happens to them after you treat them with some specific therapy. Okay. So poorly differentiated
Sir,
adenocarcinoma.
adenocarcinoma, sir.
Okay.
Followed by that, CCT abdomen and pelvis with chest was done, sir, which showed a circumferential asymmetrical thickening in the distal body and pyloric antrum and pyloric canal for a length of 12 centimeters with a maximal thickness of 27 mm, sir. And posteriorly, the thickening is abutting the pancreas with loss of fat plane with head of the pancreas, and there were few perigastric and peripancreatic lymph nodes present. And small oval soft tissue density or fibrotic nodule in the left posterior basal segment of the lung. Query metastasis they have given.
Okay, Pawan. With these findings, what will you do?
Sir,
What's your
actually,
complete diagnosis now? And what will you do?
sir, see a stomach with metastasis, sir.
Metastatic cancer, stomach cancer. Okay.
Sir, I would like to go for palliative therapy, sir.
But if that lung mets, okay, how will you prove
Yes, sir.
that it is metastatic only? They have said query.
Sir, CT guided biopsy you can try, sir.
If it is negative,
Sir, PET CT, sir.
okay, you do PET CT, FDG avid nodule is there in one scenario. FDG
sir.
avid nodule is not there in another scenario. How does it change?
Sir, if FDG positive means, so it's a confirmation of CA stomach with metastasis, sir.
Okay,
So I would like to go for palliative therapy, sir.
why?
Because this patient is and sir, as this growth, as the patient having obstructing kind of growth, so we can go for
No.
FG.
I'm asking you why palliation.
Sir, because it's metastasis, no, sir.
Okay, so
And the age of the patient is also 72 years, sir. So if you plan for surgery, it's a morbid procedure, so he can't tolerate, sir.
no. In surgery, there is palliation. I'm not asking you about that.
Yes,
Why
sir.
you said if there is like lung met, you'll go for palliation in a case of CA stomach. What
Sir,
is
I
the
don't.
5-year survival?
What, sir?
What is the 5-year survival rate in these patients, and especially those patients who have stage 4
Sir,
metastatic CA stomach?
sir, I don't know exactly percentage.
Approximately. Anybody else? Nikita?
Yes.
Stage 4, I'm not sure, sir, but generalized it's around 70%, so 50 to 70%, 5-year survival rate.
50 to 70%. It is too high.
So
Indraja?
stage 4 only 6 months, 6 months to 1 year. Stage 4 disease.
That is what. So most of them die within 6 months to 1
6
year.
months.
So
Yes, sir.
5-year survival is around 10 to
15.
15%.
Okay.
Sanya, am I right?
Yes, sir. With stage 4, the survival is very less. Only few
So
months.
it is one of the worst cancers, and especially metastatic cancers. So
Yes,
you
and
have to
poorly
probably
differentiated.
cause the least amount of morbidity to the patient with giving quality of life
Yes, sir.
to the patient. Okay. So that's
Yes,
why
sir.
I said you won't do anything too aggressive.
Yes, sir.
Okay. So
Yes, sir.
however, if FDG is also like a PET also is negative and FNAC is also negative, then what happens?
Sir, even if FDG is negative, sir, the mass is it abutting the pancreatic, sir. Pancreas, sir. There was yes,
I'm
sir.
talking about correct. You're talking about the local mass. Okay.
Yes, sir.
So
Sir, it is a locally advanced disease, sir. So we can't do the surgery, sir. In this case,
why?
also we have to do the palliative surgery, sir, to
Why?
relieve the symptoms.
Why?
Because it is like there is no plane between the head of the pancreas and the mass, sir. It is locally advanced disease.
Sir, abutting andre we can do surgery, I think.
We have to like intraoperatively assess if at all if you go for surgery. But if it is
Yes, sir.
what have they mentioned as they mentioned infiltrating or
Abutting, sir.
So they mentioned
no,
loss of fat
loss
plane
of
is
fat
there.
plane is important, Vinod.
Yes,
If it is just abutting, there will not be loss of fat
Loss of
planes. If loss of fat planes they mentioned, it will be invariably infiltrating pancreas.
Okay.
Okay, so in those scenarios, it will be like
Palliative.
just palliation.
Pancreatic.
How do you palliate if it is infiltrating or
yes.
if it is not infiltrating? But there are extensive lymph nodes and peritoneal and omental nodules. That is one scenario. One, it is infiltrating.
Yes, sir.
So how will your management differ?
Sir, omental or peritoneal deposits is there. We have to do feeding jejunostomy, sir, like,
Huh?
to give the feeds to the patient.
How will it improve quality of life?
If in
Outcome is
case of
very
a
poor.
peritoneal and omental deposits, sir.
Whatever it is. Peritoneal omental deposits also.
Or palliative.
What is the best
Yeah,
form of palliation
like
in CS stomach? You can do palliative resection and then do GJ. That is the best
yes,
form
sir.
of palliation in a case of CS stomach, where you
Yes,
will
sir.
avoid bleeding
sir.
episodes, and also the quality of life will be good. If you do just GJ, even there is, you can resect the local mass, there invariably that stomach growth will infiltrate into the
Yes, sir.
anastomotic area also. So if at all, if you have gone in and if there is possibility of resection without this thing,
Yes, sir.
that is the best form of palliation in CS stomach.
Okay,
Okay,
sir.
that is one part where
Yes,
you
sir.
can operate. If you can't operate,
Yes, sir.
in the sense if patient is not fit for surgery, what will you do?
Stunting.
Just like
We
put a stent.
We can place a stunt, sir. Endoscopic stunts.
No, that is what. What is it called? How will you put a stent?
Endoscopic self-expandable metallic stent, sir.
Correct. But where there is obstruction, no, how will you put? Hello? Hello?
Hello, sir.
Yes, sir.
Yeah. How will you put when there is obstruction?
Hello,
No?
sir. Yes.
You said there is endoscope could not be passed.
Yes, sir.
So how will you put?
Yes.
How will you do stent? If at all, if you can do. Before stenting, what you have to do? You have to endoscopic balloon dilatation.
Sir, I'm not.
Endoscopic balloon dilatation.
Okay.
You have to pass a guide wire, slowly
Dilatation.
try to
Yes, sir. Yes,
do
sir.
a balloon dilatation, and then
Yes.
put a stent across, metallic stent if it is possible.
Stent.
Okay. Along with the endoscopic, self-expanding
Yes,
metal stent in the pylorus, what else? What other thing you will
Yes,
want
sir.
to do before placing the self-expanding metallic stent? You want to put one more stent somewhere?
Mm.
I'm giving you a hint.
Yes.
Where? Why, Nikita, pancreatic duct?
As it is abutting into the pancreas, and also there
No,
could be a chance
how is
that
it
could be
important? Pancreatic duct, why you want to cannulate? More important than that, invariably it will involve the
Duodenum.
biliary tract, not the duodenum. That self-expanding metal stent will go into duodenum.
Yes, sir.
So once you put a metal stent into duodenum, invariably this malignancy will infiltrate into the biliary tree.
Okay.
So they will develop obstructive jaundice. So once you put
Yes,
a
sir.
metallic stent there, you can't go and put a metallic stent into the biliary tree later. So if at all in those scenarios, advanced cases, preferably put a metallic stent into the
Yes, sir.
biliary system, as well as after that you put the metallic stent into the duodenum if it is feasible, and if patient is not fit for anesthesia. Okay, so that is non-operative option.
Yes, sir.
Okay, and what else you can do
Yes, sir.
for
Yes.
feeding? Feeding preferably best form of palliation is to put a GJ and allow the patient to eat, or put a metallic do dilatation and put a metallic stent and allow the patient to eat. Doing FJ will not give him any palliation or satisfaction. Okay, it is just to keep the
Stent.
nutrition, but that is again you will get
Yes,
the
sir.
met will get involved in that area. So it is better not to do that. Any other option is there? If there
Yes,
is
sir.
distal obstruction as well, what else you can do? If there is distal obstruction at multiple levels
Yes, sir.
and also pyloric obstruction, what else? What you can do? What else you can do? How will you decompress the stomach? Anyone? Pawan?
Sir, I don't know, sir.
Nikita?
Sir,
Praveen?
palliatively we can go for feeding jejunostomy, sir. But
What?
feeding jejunostomy.
That is okay. For obstruction, what you will do? That is for nutrition.
Yes, sir.
But if it is like too much of a like obstruction at multiple sites, that also you can't do. You can do a percutaneous gastrostomy.
Okay, sir.
Okay, that is one option. And now if the facilities are available, there is an option for endoscopic gastrojejunostomy. Okay, why lumen opposing metallic stents are available where you can do an endoscopic GJ if the facilities and technical expertise is available. That is one more option, minimally invasive. Okay, so all those are advanced. So in this case, now most likely looks like a metastatic CS stomach. So you have to do some kind of palliation. So what will you do, Indraja? Hello, Indraja? I think she has logged out. Nikita?
Yes, sir.
Yeah, next, what will you do?
Sir, in case of him, the main chief complaint is about food intake, sir. So,
Okay.
so we will prefer giving him nutrition, sir, by either by Riles tube or liquid diets.
How will you give nutrition by Rayleigh tube, Nikita? There is distal obstruction,
Yes, sir.
gastric
Yes,
outlet obstruction.
yes, sir.
Pawan,
Sir, in this patient, we will go for palliative chemotherapy only. Palliative therapy, sir.
what is palliative therapy?
Sir. Sir, as you said, no, sir, if intraoperatively, if the mass is, we can able to
Now
resect
it
it,
is,
we will go for
no. In this case, already there is abutting with loss of fat planes. So invariably, you won't be able to resect. Okay.
Yes, sir.
So in that scenario, what you will do?
Sir, placing stent, sir.
Okay. Stent
Endoscopy.
placement,
Stent.
you will try, you will fail. Then
Then
I've told you
PEG.
all the options.
Sir, PEG, sir, PEG.
Why PEJ? How will you put PEJ? PEGJ you're talking about.
X, sir.
How will you put? You are not able to access the jejunum, no, because there is complete block. I said endoscopy, you can't do anything. What surgery you will do? Indraja?
Yes, sir. Sir,
Hmm?
sir, I'm
Hello?
not. Yes, sir, I'm not sure.
I gave you all the answers. No,
Sir,
it is
palliative
unresectable.
gastrectomy,
Huh?
gastrectomy, palliative
That is what
gastrectomy, sir.
it is unresectable. I am telling. In that scenario, what simple gastric
Gastrojejunostomy we
jejunostomy? What
can.
is there? What so much of a scientific this thing it is there? I have explained you common sense. Gastrojejunostomy. What gastrojejunostomy you will do?
Sir,
Anterior or
anterior
posterior?
gastro.
Anterior.
Yes, sir. Yes,
Why not posterior?
sir. Posterior we have to come retrocolic, sir.
Okay, so what is there? You come
So
retrocolic.
there will be seeding of the tumor cells, so that's why we will prefer anterior.
Seeding of tumor cells. Already there is metastasis or locally advanced. So how can it seed? By doing a posterior GJ. Pawan?
So the growth infiltrating the pancreas, no sir. So it will infiltrate the growth and it may cause luminal obstruction.
What infiltrate the growth? You mean infiltrate the GJ? Hello?
I'm thinking, sir. I'm not sure, but
No, correct. You talk about infiltrating GJ, not
yes,
the
sir.
growth. That
That's
is what. So you have to anterior GJ is better in such scenarios. Okay. So you do
Yes, sir.
palliative GJ if it is unresectable. Okay. So I'd
Yes, sir.
preferably do a GJ and JJ or RONY GJ. Okay.
Okay, sir. Yes, sir.
Or simple thing is anterior GJ, but anterior just GJ, doing a GJ will increase the bile reflux and will not palliate the symptoms. Okay.
Okay. Yes, sir.
So that is one thing. So you're done GJ. What will you do next? Indraja, fast. It is 10:15.
Yes, sir.
You're done GJ. What will you
Yes,
do
sir.
next? Pawan.
Like follow up you're asking, sir?
No, what will you do next? Not
The
only
chemotherapy,
follow up. What chemotherapy?
cisplatin based chemotherapy.
I don't think they will give for palliation. They will give
No
cisplatin based
chemotherapy.
chemotherapy.
Yes.
They'll either give capecitabine, oral tablets, most likely. I think if Sarup was there, it would have been best. But you people
Yes,
can
sir.
ask him. I want you people to
Yes.
write a essay for
Yes, sir.
GJ types. Okay,
Yes, sir.
types of
Okay.
GJ and modalities of doing GJ. How anterior, posterior, pros
Yes, sir.
and cons of each of it, and when
Okay.
when will you do what?
Okay, sir.
Okay,
Yes,
fine.
sir. Okay.
So palliative chemotherapy probably plus or minus depending on what the attenders want. If the attenders are okay with just leaving him alone and palliating his symptoms, do GJ, allow him to eat, palliate his symptoms of pain and this thing, because outcome will be very poor if there are
Very
already
good.
lung mets.
Yes,
Okay.
sir. Yes, sir.
So patient will invariably die in 6 months to 1 year.
Yes.
So you can try palliative chemo. Probably it will be a capecitabine tablet. That is what, as far as I know. You
Yes,
can
sir.
ask Swaroop tomorrow and clarify. Okay.
Yes, sir. Yes, sir. Yes.
So,
Yes.
so that is what probably will be best for this case.
Okay, sir.
If it was, there is one more scenario. If there is no lung met, if it is only locally advanced CS stomach, then do GJ. Okay. And
Yes, sir.
then give what? Neoadjuvant
Neoadjuvant
chemotherapy.
chemotherapy, sir.
See how the tumor responds to the neoadjuvant chemotherapy. After three cycles, I think you need to assess what is the response by doing a repeat endoscopy and also this thing. But in that scenario, and probably a PET. Okay.
Yes.
So
Yes,
if
sir.
there is a resolution of this thing, probably if it becomes from unresectable to resectable, you can go ahead and do a definitive surgery and then complete the adjuvant chemotherapy. Plus
Yes,
or
sir.
minus radiotherapy, that is again a controversial topic in CS stomach.
Yes,
Okay,
sir.
if people go ahead and read about it. It's already 10:15. If any other questions?
Sir, in operable cases also, they are telling like neoadjuvant chemotherapy we have to give first, followed by the surgery, sir. That will
That
give
is
the
again
best result.
controversial. You people
Yes, sir.
stick to whatever the recommendations are there in the standard textbooks.
Okay, sir. Okay.
Okay, so generally for
Yes.
CS stomach, surgery is the preferential modality of choice if it is operable, followed
Yes,
by
sir.
adjuvant chemotherapy, depending
Okay.
on the stage. So
Yes.
neoadjuvant CT is a controversial topic for operable stomach cancer. I know there
Okay,
are
sir.
studies which are going on, and there are certain papers who have suggested neoadjuvant CT has to be done, and then surgery, and then CT or plus or minus RT, and they have said outcomes are better. But they are
Yes, sir.
all small individual studies. There is no definitive guidelines that neoadjuvant CT across board will work better. So
Okay, sir.
still, according to standard textbooks and this thing, neoadjuvant, the ideal treatment of choice will be surgery if it is resectable, followed by chemotherapy.
Chemotherapy.
Yeah, plus or minus RT, adjuvant chemotherapy. If it is
Yes.
unresectable and if it is non-metastatic, you can give neoadjuvant chemotherapy. Even in metastatic, if it is only restricted to abdomen, you can try some chemotherapeutic regimens if the patient is fit enough and if the
Yes.
attenders want to go ahead with every form of treatment, and then probably assess after 3 months, and depending on the outcomes, you can go ahead with the further treatment.
Okay, sir.
Okay. Any other
Yes,
questions
sir.
from anyone?
No, sir.
Pawan,
No, sir.
Vinod,
No, sir.
Nikita?
No, sir.
Okay. Sanya, you have any comments or anything to add?
No, sir, no, nothing. Everything was covered.
Okay. Okay. Then we will end the class. Okay. Yeah.
Thank you, sir.
Thank you, sir. Thank you,
Yeah.
sir.